This meeting is being recorded.
Good afternoon, everyone. If you will please go ahead and put yourselves on mute, and you do not have to be on camera for this session at all. You're welcome to, but you do not have to be.
Ideally.
We've got folks that are joining in, and happy to have you all today. And let me just get started by saying thanks for coming today. Originally, this was set up as a webinar
I can't
for the Arc
turn
of
it
North
down.
Carolina. And because we've had such a wild week in North Carolina, we decided to make this a meeting. And there are lots of you guys that have shown up, and you are not required to be on camera. We do ask that you go ahead and mute yourselves. We don't need to see you, but we're happy to see you. But we definitely don't want to hear you right now. Please use the chat feature if you have any questions throughout this Zoom session, and we will get to you. Okay, so welcome again. My name is Melinda Plew. I am Director of Advocacy and Chapter Development for the Arc of North Carolina. And with me today are both John Nash and Lisa Petit, Executive Director and Deputy Director with the Arc of North Carolina. And we have come together this afternoon to kind of give an update of what we know and what we don't know, and hopefully assuage some of your concerns or anxieties if you are a family member or a self-advocate walking through this Medicaid transformation journey in North Carolina as we are. I am recording today's Zoom session so that you can go back and refer to it later if you want to, or share with those in your teams or with others that may need to have it. So with that, I'm going to turn my camera off, and I'm going to turn it over to John and Lisa.
Yeah, and I am going to.
All right. Welcome. We're glad you're here. As Melinda said, these webinars are a continuation of gatherings we've had starting last spring, and we'll keep doing these as actually probably going forward. These seem to be a good opportunity for everybody to get together and for us to be able to talk about things that are going on. Just to remind you that the basic ground rules for us is we will share what we know, and there's an awful lot that we don't know. We need your questions, because we take your questions, things that we don't have answers to, and we're turning around and bringing these back to the department and sharing that with them so that we can get answers, hopefully sooner than later. We understand that there is a lot of turmoil and a lot of changes have occurred just in the last few days. Today was Deputy Director Dave Richards' last day at the Department of Health and Human Services, who is overseeing this project. That's, that is as it is. We wish Dave well. He's been a good friend. He was my predecessor here at the ARC. So he's been around, and I expect we'll hear more from him, certainly going forward. That being the case, there's still lots of things going on. We were also announced, it was announced last week that yesterday, that Medicaid, we heard late last week that it was going to happen, and the official announcement came yesterday that Taylor Plan launch is now postponed to October 1st, and that certainly is causing angst and stress for a lot of people. So we want to talk a little bit about that and what that means, and just to let folks know that things are moving forward, and talk a little bit about what we're aware of on that. And so with that in mind, the first thing that I wanted to pretty much share with everyone is that Taylor Plans and Taylor Care Management are two different things. Taylor Plans are the organization. That's the LMMCO that we all know and love, Alliance, East Point, Partners, Sandhills, Trillium, and Via. Those are the Taylor Plans. That Taylor Plan launch is what is postponed to October 1st. Taylor Care Management, which is what the Taylor Plans, the companies, are supposed to be doing. Taylor Care Management started up last December and is going on as of today. They're still working on getting the assignments correct. There's a lot of work to be done there, but Taylor Care Management is not postponed. It is actually ongoing and live and active, and will continue to be active. And so we and a number of other organizations like us have Taylor Care Managers, and we are helping to facilitate connecting you with the resources and the services and the activities you need. And so I've run across a few people that have been confused because we use the same terms. The state made these decisions, and you know, I think at the time it made perfect sense because it keeps it all kind of sounding the same. But when things like this happen, it gets confusing. And so when somebody says tailored plans have been postponed, tailored care management is going and happening and will continue to happen. Tailored plans, again, is the LME MCO, or the six: Alliance, East Point Partners, Sand Hills, Trillium, and Via. And in case anybody wants to know, I have a cheat sheet just so I can get them. I don't forget one. Those are postponed. Their role in this is postponed until October 1st. And so there's some work to be done. So with that in mind, again, I'm John Nash. I'm Executive Director here at the ARC in North Carolina. We're glad you're here. And I'll let Lisa Poteet, our Deputy Director here at the ARC, introduce herself.
Hey, everybody, I'm Lisa. It's good to see you. And you brave people who turn on your cameras, I want to thank you because it's helpful to be able to see your faces when we're talking and not just a black square with your name in it. So feel free, show us your faces. It's helpful, especially if you have a question. So the news yesterday was big that the tailored plans won't actually launch until October 1st. And while some people get that tailored plan, tailored care management confused, here's what I do that helps me. I just call it care management, not tailored care management. So the tailored plan, remember, is like an insurance plan for Medicaid recipients. So what's the standard plan, right? And then we have care management. That is the function that the goal is to bring together all services and have them coordinated by one person, that being the care manager. They're not in charge of telling your doctor what they can do or telling your service provider what they can do. They are the coordinator. We refer to it sometimes as the quarterback of the team. They're the coordinator of all that goes on in a person's life that Medicaid is paying for, and maybe some other things too. Maybe that person needs help coordinating transportation, or help getting some food, or help finding housing. So that care manager would also connect them to other resources. So like John said, care management keeps rolling, doesn't stop. Just we keep going with care management while we wait for the tailored plans to actually launch in October. One of the main reasons the state has postponed the launch, as you might imagine, is because the tailored plans have been working hard, but having trouble getting all the hospitals and doctors and specialists signed up with them as the insurance plan they're becoming. Doctors and hospitals have to be in network in order to get 100% of that Medicaid rate. That process has taken on a life of its own and has taken much longer than anyone anticipated. This was one of the reasons they postponed the tailored plan launch the first time. And now it's a reason why they're postponing that again. So we have, while it seems stressful that this keeps being pushed out and postponed and the message seems to keep changing, what I want people to focus on is we have another 6-month window, which is a gift. A 6-month window to get doctors to contract with the tailored plans, specialists that we know you all need, and hospitals. I surveyed all the LMEs over the past week to see what hospitals do you have in your networks. Some are doing really well. Some haven't responded yet, I would say. That doesn't mean they're not doing well. Some told me to go to their provider list on the website, which was confusing, and I couldn't find what I needed there. But I can tell you, for instance, Alliance is serving half the Medicaid members in the state. They signed a contract with UNC last week. They have a contract with Duke. They have a contract with Novant. They are big. They're in all the major metropolitan areas, and they're getting their hospitals to sign on. I think others will follow suit, and the more rural hospitals and regional hospitals that we have may lag a little behind, but they will be signing on. There's a lot of work to do with all the doctors out there. to get them to sign up as well. So this is the major reason why we have a 6-month extension. I think it's a gift to everybody who was very worried about, am I going to have my doctors? Am I going to have my hospitals, my clinics, my specialists that I need? Now we have a lot more time to get those folks signed up with the LMEs, soon to be tailored plans.
So one of the other questions that is coming up is, so we bumped things back, the state bumped things back 6 months, which means the go live is 6 months down the road. But I'm in tailored care management. I'm in care management now, and things are changing. So what happens? Am I still going to be able to see my doctor? And the answer is yes. For the short term, the state has guaranteed all providers, all medical providers, that they would be covered at, technically it's called out of network. They're not signed up, but the state's going to pay the bill anyway, because they're already signed up. They're already connected to Medicaid. So if you've been seeing your doctor and they've been taking care of your bills, this transition for the leastways the next 90 days, that's the last word we had, they will continue to be paid and reimbursed exactly as they have been. So nothing changes. And at the same time, your day supports, your long-term services, your in-home supports, all the things you've been getting through the other Medicaid channels through folks like us and other providers, those will go through the standard plans or the tailored plans. The rest of this will just be billed as it has been for the time being. Now, that's 90 days, and we're told that we have 6 months, in effect, 180 days before the go live. In that interim, if there's a problem, they've already done it once, I'm pretty sure the state would say, we will extend. Now, I can't guarantee that, but they've already said we will keep things going. We want to keep people safe and whole. So they'll continue to do that, I think, as long as there's not another alternative out there. And right now, this is the alternative. So at least ways for sure for the next 90 days, your doctor bills will be covered exactly the way they have been for the last however many years. Your day supports and your long-term services, those things that you've been getting will now be handled through care management, which is what we're already doing. And we'll make sure that, and we and the others like us, everyone is, I think, committed to making sure that the people we work with are well taken care of.
I don't know if you guys are following the chat, but Benita asked a great question, and it's this: what are the barriers to doctors signing on? It's actually 2 questions. My sister has Medicare and Medicaid. How long will the tailored plans pay out of network once it goes live? Let me talk about some of the barriers. If I'm a doctor, especially in a small town or rural area, I may not have a lot of administrative support. And to contract with an LME, soon to be tailored plan, is yet another insurance company that I have to work with. If I am a large doctor's office, physician's group, then I may be saddled with having to contract with all 6 of the LMEs, soon to be tailored plans. That's a lot of business that has to be handled by someone in my practice. If I have an office manager to handle that, I'm pretty fortunate. If I do sign on with the 6 tailored plans, I have to get authorizations for medical services in 6 different ways. I have to file Medicaid claims in 6 different ways, potentially be paid in 6 different ways, potentially 6 different rates, because eventually they'll have some rate setting authority, although they'll have to maintain a floor. They can't go any lower than a certain rate. So if you think about a doctor's office already signed up with, and this is just for Medicaid members, right? Already signed up with 4 of the standard plans, maybe 5, for the majority of the Medicaid population. Now I got to sign up with 1, 2, 3, 4, 5, or 6 more for people with more intense needs who are going to be in the tailored plan. That's a lot. That's a lot of business operations. That's a lot to consider. And if you're a doctor considering that, and you get paid the Medicaid rate, which is not as good as some private insurance rates, then you really start to question, is it worth my while? And while many doctors are very committed to folks with IDD and their families and have long-term relationships, it comes down to a business decision for a lot of people. You have to be able to exchange data, which we're also trying to figure out how to do that correctly, because there are issues with exchanging all this data all over with all these entities across the state. And so it's very complicated, especially for a small office. So those are some of the barriers that doctors are facing. And we applaud the ones who are signing up because we need them. And we realize it's going to be extra work because we're doing it ourselves. And we're hoping that the state will work with the LMEs to streamline some of this stuff to make it easier for doctors and others to sign up to be in network with the tailored plans. Benita's other question is also important. How long will tailored plans pay out of network once it goes live? So their plan was, Benita, before they postponed it 6 months, when we thought it was going live on 4/1, they were going to pay an extra 90 days, regular Medicaid rates. So that would have been 5/1, 6/1, 7/1, 3 extra months. They were going to continue to pay those Medicaid rates and give that 3-month window grace period, if you want to call it that, for those doctors to get on board and get those contracts signed. At the end of those 3 months, those 90 days, likely they would have dropped that. They did this when they launched the standard plan. So we haven't not heard confirmation. This is just guesswork at this point. But I believe since they did it with standard plans, they were going to do it for 4/1. I believe they will do that for the 10/1 launch as well and pay those Medicaid rates for an extra 90 days past the 10/1 launch. That seems to be their standard plan. Not to be confused with standard plans. That seems to be their standard process. So we will be watching that and asking that question, but that's an assumption on my part that they would do that again.
It's pretty much what we're thinking. And again, keep in mind, it is in their interest to make sure that nobody falls through the cracks. And believe me, there's a number of us pressing very hard to do just that, so that if there is a gap, that there is a way to address that gap, so that people don't lose out on the services and the medical doctors and the different specialists that everyone in this group really needs. And this is such a critical element to the IDD community. Again, we'll be paying very close attention to it, but if you run across something, by all means, let us know. If there is a hole or somebody slips through those cracks that inevitably is going to happen, we're certainly want to be aware of it so that we can do all we can to help make sure that people get what they need.
There's another great question in the chat from Linda, and it says, will community navigation end March 31st or continue until October? I'm going to give you a 2-part answer. Sorry, it's not Linda, it's Lindy. Lindy, the first answer to that is community navigation will continue indefinitely only for self-directed portions of that service. So for agency of choice and employer of record, that one small sliver of community navigation will continue indefinitely. For the larger group that's receiving community navigation, or it may be community guide if it's funded under the B3 dollars, that will continue. We don't have an end date for that yet. The goal that the state has set is that it will continue until people begin receiving care management. And they've given us one transition month where people could receive both community navigation and care management so that we can transition them to the care management service, because community navigation is seen as being very similar to care management, although care management does a lot more. You can't do both for the same person for a long time. So past that one transition month, you can't do both. I will tell you internally, our strategy has been and will be to go ahead and transfer people from community navigation into care management as soon as we can. And we'll continue providing community navigation until we get them transferred over to care management. Care management is a fuller service for people that we believe can do more for folks. So in most instances, you may not want to hang on to community navigation if you can get the care management.
So Benita asked a really good question. It's one that we've been talking about internally for a variety of reasons. The question is, because Medicaid's based on the county of origin, individuals living outside of that county of origin may need services. And actually in our world, and we know this, anybody that has a family member with an intellectual or developmental disability, we know, and I have family that does this themselves, will drive 2 and 3 and sometimes 4 hours to get to a doctor that meets the needs of their loved one. Because sometimes the needs that we have are that specialized, and we have a hard time finding people that know how to work with us and with our children and with our loved ones. And so that means that somebody may be going outside of the area where they live to get to a doctor that is in someplace else in the state. And if you draw a 4-hour circle around any doctor, that means just about any doctor may touch all 6 of the soon-to-be Taylor plans. And that's complicated. And we think that may be part of the reason why some of the doctors are hesitant, because it's not just enough that if I live in the Alliance catchment area that I sign up with Alliance, I will also have to sign up with all of the other 5 on top of that, because I may get people coming from anywhere in the state to use my services. And so we believe that that will be taken care of, and that you can get your doctors outside of your catchment area. And that's part of the reason I think why all of them have to get these panels right. And that's why we are working at, and we would hope that you all would reach out to your doctors and say, hey, if you haven't signed up, help, we need you. They still have to make that business decision. And I believe the state's working on some effort to hopefully pave that way and make it a little bit smoother. But like I said, that problem is what faces the IDD community across the state, regardless to whether it's a hospital or a specialist that is specific to the needs that your loved one has. And so it's a complicated question. Debbie Brown asked a great question. Where do the Taylor plans come from, and what are their benefits, and why do we need them? How compared to how Medicaid was billed before? And that actually goes back a lot of years. Interestingly, that sometimes this whole transformation has been promoted as a cost-saving measure. And the reality is, and talk to the people that helped put it together, it was never intended to be a cost-saving measure. It was intended to be a cost-controlling measure. And there was 2 different things, because the spend on people with disability, on mental health, on substance use needs, traumatic brain injury, the costs go up and down and vary month to month in a very wide, I mean, it can be really high one month and almost non-existent the next month. And it's really hard to plan and budget for something that you can't control. And so originally the idea was to go to managed care, which means that you write a check for one person. If you take a pool of 100 people, some people need a lot, some people need a little, some people need average in between, and you average all that together, and that much money is how much you spend on that group of 100. You send for all of them at that average rate. Originally, we started out doing just habilitative, long-term services and supports, and behavioral health as that managed care approach. But physical health was always fee for service, and a fee for service is where, when they do the little barcode when you go in to get, to go to the doctor, and they give you an Advil if you've got a pain, and they scan the barcode and you pay $10 for the Advil. It's those kinds of things. Each service has a fee attached to it, and that's called fee for service. That's been fee for service up until now. The new plan is whole person care, and that's where the Taylor plan really becomes a critical thing. And we actually applaud the effort to do this, because we all know that your health care is not separate from you as a person, is not separate from everything you do in a daily life, going to work, living in a home, the activities you engage in, the things that you do. It is all connected. You can't disconnect one piece from the other. The effort from the Taylor plans from care management that we are doing is to bring all those pieces under one roof and help coordinate you and serve you as the individual. Instead of we're going to treat a condition, we're going to help you as an individual get what you need to be able to thrive and to do better and to do well. That's the original concept. This goes back 15 years. We've had the innovations waiver as the first part of that. Now we're shifting to this entire whole person approach. And that's really where the Taylor plans came from, is the intent to not just serve the physical health and not just to serve the long-term services and needs of an individual, the work, the housing, the transportation, all those pieces come in under one roof. And our role as care managers is to help you connect with those services and to make sure that you need. So that's the quick answer as to why Taylor plans. It's obviously pretty complicated. Even for those of us that are in the middle of it, it's complicated, and there's a lot of pieces to this. So why we do this as a group, it's kind of a team effort. Everybody's got a different piece of this, and we try to stay on top of that. So that is the quick answer about the Taylor plans. Let's see. Got some
Leanne.
great in the chat. Go ahead, Lisa.
Leanne asked a good question. Every time I call or ask about my son's doctor not being a network, I'm told by the state to call and talk to your doctor. Obviously, in a large hospital system like Atrium, my son's doctor is not the one making the decision or even knows who to contact about such a decision. How do I communicate that this is not a viable answer or solution to my questions by telling me to contact my doctor? That is something we have struggled with. We have even advocated for you to call your doctor, not your hospital. Hospitals are big. You'd be lucky to get into, the right person at the hospital who's making these decisions. We believe it's an extra burden on families to tell them to call with their doctors. And yet we have advocated for you to do that because you have a powerful voice. And it's going to take all of us to get doctors there and to make this happen. We hope that when doctors hear from you and hear you saying, I really want to continue my relationship with you, I really need your services, please sign up, they will consider or reconsider. We've even put a letter up on our website that you could use. You could pull that letter down, fill in your personal information and take that to your doctor, give them something in writing. We don't know, honestly, how much that's going to persuade people. If they'd streamline the process a little bit, that would certainly help make it easier for doctors and providers to sign up. But it never hurts to exercise your voice. I realize it's harder with a hospital. I do believe, and from the research I've done in the last week, and I'll give you mentioned Atrium, I'll give you an example. I don't know where in the state you are, Leanne, although I feel like I'm supposed to know that. But Alliance told me that they have a letter of intent from Atrium, which means they're very close to working on a contract, and that the state had said they could use a letter of intent to pay them Medicaid rates. That's an indication to me that it's moving. It's not done yet. And so fortunately we have the 6 months, but it's moving. Even Atrium, in the larger systems, Novant, UNC Duke, Cone, those hospitals are signing up. It's starting to happen. I'm just thankful we have another 6 months. It's not practical for you to all to call hospitals. It may be practical for you to all to call your doctors.
On top of that, there's another option that you might have, and actually I would encourage you to exercise it. Last week, we met with many of our leadership at the North Carolina General Assembly. We had conversations with many of them from around the state, particularly those that are engaged in the health and human services activities and arena, and had some really good conversations. And one in particular extended this invitation, which we would encourage you to do anyway. And he said, you know what, when you run into a problem on a roadblock like that, he said, give me a call. I can imagine we will, and we've had this happen before. People walk out here and say, hey, John Nash said to give you a call. I might get a phone call, but you know what? I'll take those calls. And here's what will happen. If you call your legislator, the likelihood is your legislator cannot lean on your doctor, just like the issues, the question was, my doctor doesn't even know who to talk to within their organization to get them to sign up. But that's not where the legislator is going to go. The legislator, in turn, is going to go back to the Department of Health and Human Services and to the people that are leading the LME MCOs, the Alliance, East Point Partners, Sand Hills, Trillium, and Via. And they're going to go to them and say, why is it that people from my district are calling me saying, I can't get my health care? That has a huge, huge impact. We've done this kind of thing before, and we've actually had legislators call us telling us, would you please tell your people to quit calling? But it's that voice of the public, and probably more than in all the years that I've been doing what I do, this group of legislators is more responsive to their constituents, to each of you. You pick up the phone and say, even if it's just as simple, I'm not sure what I'm supposed to say other than I can't get to my doctor. I have an intellectual or developmental disability, or I have a loved one that does, and my doctors aren't signing up. What should I do? And if one of you calls, believe me, it gets their attention. And I would not be saying it quite this way, but we had a legislator say this to us last week. If you have somebody who has a problem, have them give me a call. That was his words, almost verbatim. So the system needs to move. There is work to be done. We believe that work is being done, but having a legislator on our side saying, yeah, you guys need to pick it up and move it just a little bit quicker is not a bad thing. Is it going to expedite things right now? I don't know. It's a question I don't have an answer to, but I can say it certainly doesn't hurt to have the legislature looking at that and making sure that there is a fire lit to keep this going, because sometimes people get casual. You know what? We got past that April 1st deadline that we had. Now we got till October. We can coast a little bit. We want to make sure that they don't coast, and we will be there with you, and are actually making some of those calls ourselves to doctors saying, what do we need to do to help your doctor panels sign up? So, and again, write a letter, pick up the phone, make a phone call, and you'd be surprised how many legislators will respond to your requests of, what do we do now?
I'll help you guys with questions in the chat. Lisa, was there something that you wanted to mention about our waiver before we flew it?
Yeah, most of you probably have heard about the I option that the state has proposed to CMS to develop a new funding source, which is also Medicaid dollars for community-based services. They're still waiting for the I option to be approved at the CMS level. CMS is Centers for Medicaid and Medicaid Services. We are hopeful that this would get more community-based services out to people. The plan was to transfer first the group that's receiving B3 funded services over to the I option services. We expected it would be ready on April 1st. It would coincide with the Taylor Plan launch. We don't think it's been, we know it has not been approved yet at the CMS level, and it has to be approved before the state can launch that. So we have a little extra time. This is also a gift. This is a good thing. B3 services can continue. In the meantime, we'll wait for the I option. We want them to get it right. To try to roll out Taylor Plans and I option all on April 1st, April Fool's Day, no kidding, was not a good idea in the first place. It's too much at one time for the system to wrap its head around, and much less get your hands in there and make it happen. It's too much change for everybody at once. And so extra time on both is welcome right now. The I option is going to happen. They're tweaking, they're working, they're negotiating with CMS right now for the approval. It will likely roll out sometime between April 1st and October 1st before the tailored plans go live on October 1st. And we'll just wait and watch for that.
Okay, perfect. Okay, so I'll get back to the chat. Helen asks, are specialists going to need to contract with tailored plans, or is it going to be the same problem as when contracting with PCPs? And does a PCP have to make a referral?
It's the same problem and the same opportunity. Specialists will contract with the Taylor plans. We hope they will, just like the PCPs. Not everyone will, for the reasons we've been talking about. Specialists, especially in IDD world, I think, I hope, have a little bit stronger connection to folks that they're serving, and would feel more of an obligation to sign up with the Taylor plans. And I hope that will happen.
Along those same lines, Pam asked a similar question, and it's a structural question. She has a relatively small private practice specialist that is one of their providers, and getting reimbursed from a small practice. How does that work? The interesting thing about managed care is they come up with a basic number of how much it's going to cost to serve everybody, and they write a check for that amount, and you have to fit it in under that amount. In this case, the Taylor plans would be on the hook. If a specialist signed up, they would have to negotiate what the rate is for the number of people they think they might be serving. And, at that point, it's a business decision, which is partly the reason why some of them are hesitant to negotiate with 6. As you can imagine, doing it with 1 is complicated. Doing it with 6 gets even, 6 times more complicated. But that's where, again, we can advocate, we can make efforts, you can advocate, but really working with that doctor to help them get signed up on that end, and us working on our end to make sure that they simplify the process, which is one of the things that we've been pressing, is you really need to simplify this process. It is, by any standard, it's going to be complicated to begin with, but we make it 6 times more complicated if we don't figure out a way to standardize everything, which, interestingly, the standard plans, which started a year ago, that's Blue Cross, Healthy Blue, United Health, Meritos, the 5 that just do the basic stuff, they figured that out. And I would extend very publicly an invitation to the 6 LME-MCO, soon to be Taylor plans, that they would get them together and come up with those same standards, to make it easier on not just the doctors and not just themselves, but on all of us. It would certainly make our lives a lot less complicated.
Okay. Leanne asks, am I the only person who has called the majority of providers within a 30-mile radius, and 85% say they're not accepting new Medicaid patients? I'm going to assume that's a rhetorical question.
And I'd say that's a common theme. We're hearing that a lot, that you guys are calling and not getting the response you want. Again, 6 months, I hope, is going to help that response a whole lot and turn that around.
So this is great, and it's important. Does a basic orientation guide exist? As a layman, I'm very confused with the terminology, the structure, the everything.
Great question, David. I feel like I have been listening to conference presentations, webinars, reading white papers for the better part of 5 years, trying to figure out what in the world are they talking about. It is very confusing, even for those of us who do it every day now, it can still be confusing.
Yeah.
I don't know of an orientation guide. There are some white papers we can point to, but I wouldn't suggest you read them.
Not unless you have a hard time going to sleep at night. That would be, there's a lot of content out there, and we spend an awful lot of time trying to absorb. And I'll be the first one to tell you, there is no one of us, no 5 of us that can absorb all this. Usually when we get together, we're all talking about the different pieces we've seen, and it is very much a team activity. It cannot be done by yourself. That said, part of the reason why we're doing these webinars is to present as much information and let you ask the kinds of questions that you're having. I wish it were simpler. In concept, it is simple. In practice, it is far more complicated than that, especially when we're talking about somebody with an intellectual developmental disability and the complex needs that go along with that. trying to do that for just the habilitative day supports, getting people out of bed, getting them going in the morning, getting them fed and off to whatever activities they're involved in. That's complicated. And if you add in health concerns, which pretty well every one of us has, at that point, that gets even more and more complicated. And so, again, that's part of the reason why we're doing these webinars, is to give as much information as we have available. And in what I said when we started, to take back questions where we don't have answers. We found this to be very helpful, and so has the Department of Health and Human Services. And they've told us, gee, we haven't had that question before, and we're saying we saw it 6 times last night on the webinar. And so to not hesitate, please do not feel foolish about asking a question that, gee, everybody ought to know this. No, there is nothing in any of these webinars that I've seen that is a simple, straightforward, everybody should know this answer. It just doesn't exist in our world. So please feel comfortable asking before, during, and after. It makes a difference to us when we go back to the department.
So this person, and we've answered this before, but we need to talk about this every time. If a person is duly enrolled, Medicare and Medicaid, can they stay in Medicaid Direct and still get the innovations waiver?
No, they cannot. Everybody with the innovations waiver will move into the tailored plan now on October 1st. That is the only place the tailored plan will be managed. I'm sorry, the innovations waiver will be managed under the tailored plan.
So Pam's question, and I know I'm skipping one, I'll get back to it. What is going to happen healthcare wise for folks who have Medicare and Medicaid under the tailored plan?
If Medicare is currently paying for your doctor, then I'm thinking you don't have to worry about your doctor signing up to be paid by Medicaid under the tailored plan. We've had several folks ask this question, and as far as we can see, if you got Medicare paying for doctors, you should be okay. You shouldn't have to worry about whether or not the doctors are signing up for the tailored plan.
So this is a question that we probably don't have the answer to, but we understand, and it's talking about the requirements to have a psych eval every 3 years. No providers near, right? And the state does not allow psychologists to do them, only psychiatrists, and hoping that the state will change the requirements. Is there some advocacy that we can do on that, John and Lisa, too, or that families can partake in?
Lisa, I'll let you answer that first, then I'll add some thoughts on top of that. If you
There's
would.
always advocacy, yes. Today I listened to a couple of legislators lobbying, listened online for them to lobby nurses to have a broader range of practice. And so they're always looking at these things. My understanding is that psychologists could do these psych evals. Melinda, do you know that to be different?
I do not know that to be different. No.
I've known lots of psychologists to do these psych evals over the years, and we mainly depend on psychologists to do these psych evals because there are not enough psychiatrists, and not everyone needs a psychiatrist. It may be that if the person has some psychiatric conditions, somebody felt they needed a psychiatrist to do it, but that's the only reason I can imagine that the state said that only a psychiatrist could do.
I think maybe we can probably get some clarity on that. I think if it's a clinical psychologist or certain licensees, not any counselor or therapist,
that's probably
they can do them. So there probably is a list of those that can do them besides a medical doctor. Yes.
Yeah.
So let me add to that too. I mean, right now the state exists on a variety of levels we have a workforce crisis, and it is a big one and getting bigger. And it's interesting because this crisis has been brewing for a long time. The announcement today at the General Assembly, it's a bill called the CARES Act. It is bipartisan. It is floated in both the House and the Senate simultaneously, which generally means it's going to move through pretty fast because they generally put the exact same language. So it'll move through relatively quickly. but it is acknowledging, probably in the most public way I've seen in a long time, that A, we have a workforce crisis, and B, we need to do something of substance to address it. In this case, it was to allow physician assistants and nurse practitioners to function without as the significant amount of oversight they've had in the past, to actually practice under the licensure and training that they have. But that's an acknowledgement that there is a huge gap, particularly in rural areas where doctors, one of the deals was, and their comment was that if you need an anesthesiologist at 5:30 in a rural area, you're either driving all the way to Raleigh, or you're just going to have to live with it until the weekend is over, because nurse practitioners and PAs could not perform any of those services and activities that this bill would allow them to do, to give you a local anesthetic to dull the pain while you're getting treated for something. That's an acknowledgement that floats into this question, because we don't have enough PhD, or I'm sorry, we don't have enough MD psychiatrists available to us, particularly in rural areas, and we don't have enough laborers and service providers and in-home support people and direct support staff to fill the needs that we have. And so we're going to have to be very, very creative. And the ARC is already pushing some issues to be creative to help build that workforce. It's going to take some time for us to start filling those pipelines, but we're already creating an apprenticeship program to help those entry-level positions. We're also having conversations, and right now probably is as good a time as ever to be able to say, hey, listen, we've just come out of the pandemic. We already know there's a shortage of psychiatrists. Can we get authorizations? And there's a number of agencies that are working to broaden those resources out, because there is such a huge need and such a lack of resources to actually do that. So now is actually as good a time as it's ever been to make that kind of thing happen. So the partial answer is yes, there is work going on to broaden out what we can do. Second is, the more voices saying, please do this, certainly helps. And we're watching, actually, I've heard that there is maybe a bill getting ready to get sponsored sometime in the next few weeks, that the North Carolina Psychological Association might be working on. We'll see. Bills are always funny things. People can float things out there, but what it looks like when it's finished may be nothing than like what it looked like when we started putting something together. But definitely we'll keep our eyes out for that.
Okay. So Anna says this is new, although we've been working on getting services for our son since before COVID. I'm so sorry. The ARC in Wilmington is unable to assist because they are down people working with Trillium. This is still overwhelming. Innovations Cap B3. Where do we go for answers if your panel of 5 doesn't have the information?
I guess that depends on what answers you're looking for, Anna. We'll do our best to answer questions and help out if you have specific questions. You can certainly talk with Trillium. Some of their care managers might be able to help, or they can get you to other folks at Trillium who could answer questions. And our staff in Wilmington can answer a lot of questions. We are having trouble finding direct support professionals everywhere. Every provider in every state in the country is having trouble. We are in the midst of a workforce crisis in this area. And as John said, we have several irons in the fire to try to help bring some relief to that situation, and talking to legislators about that a lot.
Thank you, Christine, who broke in to say if the person has a PhD and the person has Medicare, then they can do the evaluation. So it's not psychiatrist, it just has to be doctoral level. Okay, let's see if we have any other questions in the chat. How does CMS factor, how does CMS factor into I'm sorry, people keep putting questions in here and I can't. How does CMS factor into allowing PAs and family nurse practitioners to do more? There are many forms required for services that require an MD to sign off, and that creates issues.
It's a good question. I don't have an answer to that. And Lisa, you might. I do know what was said today in the press conference where they announced this. We were expecting some other information, but they came out with this the HELP Act. And their comment was this is done in 26 other states. And it's done successfully. Nobody has repealed it. And it is working. Apparently, the statements, again, how accurate this is, can only assume it's accurate, but the statement was that the PAs and the nurse practitioners would be working under the licensure that they have, which includes, certain levels of training, things that they can do. Whether or not CMS allows that or not, if there is a CMS issue, then the state would have to amend the state plan to accept that, which is something that happens not every day, but it's not something that's out of the ordinary, particularly if it broadens access to care.
Okay. I think that is all of the questions that are in the chat, and it's 5:21. Anybody that wants to ask a question live that is welcome to raise their hand and do that. If typing it is not your preferred form.
Pam had a
We'll
question. It says, will the Taylor plan Medicaid pay the Medicare deductible and co-pays like they do now? Medicaid is Medicaid. So if it pays whatever Medicaid pays for today, it will pay for tomorrow and the next day and next week and next year. That's the Medicaid activity. The way it's administered in North Carolina, that's just the mechanism to deliver it. And so Medicaid itself won't change. That much is pretty comfortable, unless somebody knows something that I don't know, which is always possible. Actually, frequently possible.
Okay, well, we are so appreciative of all of you that showed up today. I mean, to be perfectly frank, we are trying to stay just ahead of you guys on all of this. And it changes all the time, and we are doing our best behind the scenes to gather information and then disseminate it as quickly and as simply as we can. But we know that neither of those things are perfect or without flaw, and we apologize for that. But we are doing our best, and we will keep on trucking. And we do have a link, and it is on our website whereby you can submit questions to us, and we will try to get them answered by our next webinar. So look for information about that to come. This will be posted on our website under our Medicaid transformation page. And hopefully you're all signed up for our action alerts and to get information about when these meetings or webinars are happening. So thank you, John. Thank you, Lisa, for popping in this afternoon and providing answers as we can about all of these changes. And as more happens, we will be back in touch with you and share it as quickly and efficiently and simply as we can. Thanks, everybody. I'm sorry.
Visit our YouTube page. These recordings are being kept there, and we're breaking them down by question. So you can just get a brief video on what the question was, so that there's some quick answer stuff that you can get to, especially if this is new to you. Our past videos on webinars are posted there so you can see them, and invite all of you to go there and take a look at things.
And keep
All
those
right, thanks,
questions
everybody.
coming.
Y'all have a great afternoon.
Thanks.
Thank you.